Okay, hi everyone. Thank you for joining us this evening. Today's tutorial is on assessing head injury given by Dr. Sanskrithi. Just a couple of rules before we start. For those of you watching via the Zoom, if you have any questions that are relevant on what's being covered in the moment, just pop them into the chat. Any questions that can wait till the end, then just pop them into the Q&A. If you're watching on the Facebook Live, just comment your questions and we'll make sure they're passed on. That's all from me, and I'll hand over to Doctor to begin. Thank you.
Hello, hi everyone. I'm Sanskrithi. I'm a recent graduate from Oxford, and I've done a bachelor's in neurosciences, and I'm currently doing an AFP at Cambridge in clinical neurosciences. So I thought I would just revise the assessment of head injury with you guys. This is going to be very kind of basic, very casual. We're going to ask me any questions as you go along. I'll try and answer them as we go along, as Hinal said. And if there's any bigger questions, then we can address them at the end, and I can give you my contact if needed. You can find me on Twitter and ask me questions there as well. Okay, so let's get going. This is a bit of disclaimer. This is not professional medical advice. This is not the Bible of all assessing of head injury. This is just a scaffold that helped me learn as a medical student. And it should all be accurate, but do feel free to check it against all the kind of guidelines out there as well. So we're going to be covering classification of head injury, the initial assessment of trauma, Glasgow Coma Scale, red flags of head trauma, and when to do CT scanning for head injury, and also a little bit about what kind of history taking you should be doing when you do an initial assessment of a head trauma. Okay, so let's get going. Classification of head trauma. So I'm going to open it out to you guys. What are the different ways that we can classify a head injury? What do you think the different ways are to do this? So just drop a comment in the chat and I'll read through it. Okay, yeah, open and closed, good one. Keep going. I'm looking for at least 5 or 6 answers and then we'll move on. Diffuse versus focal, okay. Some more. Subdural, epidural, classified according to GCS, good. Mild, moderate, severe, yeah. Full stop, whoever that is, very good. Blunt. All right, good. All very good thoughts. So I tend to go with kind of 3 different ways of classifying. It's not my own personal one, but this is what's generally used. And I'll go through them with you now. And some of them are encompassed in the answers that you've given me. So head injury versus traumatic brain injury. So these 2 terms are actually different. Head injury is any form of trauma to the head, regardless of any symptoms of neurological damage. Okay, so it can just be a fracture with no brain damage inside. It could be a laceration. That would also be a head injury. Okay, traumatic brain injury is different. Traumatic brain injury is where there's actual damage to the brain as a result of head trauma. So it's one step further almost. All right. So that's one way of classifying it. The second way is by pathology. So someone said already superficial and deep. So it could be, so think about all the structures that you would go from the outside to the inside, right? So you could have a superficial laceration that could be a skin or soft tissue level laceration. It could be fracture of the bone. It could be an intracranial hemorrhage that's not within the parenchyma of the brain. And then there's the intraparenchymal hemorrhage, which is within the matter of the brain itself. Right? So that's the second type of classification that you could use. And finally, someone mentioned the severity of injury. So this is based on the GCS, the Glasgow Coma Scale score. So that could be minimal, which is GCS 15 throughout, mild, which is 13 to 15, moderate 9 to 12, and severe, which is the lowest GCS score. When someone is GCS 3, they're not responding to anything. We'll go through GCS scoring in a little bit, okay? I think I have a question, so. I can't seem to see it. We'll come back to it later. So if whoever's typed the question, if you want to put it into the chat, then I can answer it there. So these are the 3 types of general kind of classification of head injury that we can use. All right. Moving on to initial assessment. Again, another knowledge check. What structure do we most often use when assessing any trauma case? Does anyone know? Perfect. ABC, A to E, and C, A, B, C, D, E. Perfect. That is the one that we use. So we, especially with a head trauma case, we want to use the C, A, B, C, D, E assessment format. C stands for the C spine. A, B, C, D, E. I'm sure you all know airway, breathing, circulation, disability, and exposure. These are structured in such a way because they're in the order in which things will kill you. So the lack of a patent airway will kill you first, and then the lack of ventilation of the lungs will kill you second, and so on. So that is why we check for them in that particular order. With C-spine, we're worried that if we don't have a stable C-spine, the rest of it might not really work. So I'll go on to it in a second. So any high energy trauma, especially falling from a height, you want to make sure that you've made sure that the C-spine is intact. I'm getting a lot of questions on the Q&A, but I can't seem to open it. Hinal, can you help me out? Let's continue with the C-spine. So always at the start of any assessment, you need to consider the immobilization of the spine. And that can be with collars or collars and blocks and tape. I'm not going to go into exactly how you can how you immobilize the spine, but I'll mention what they are. Okay, I have a few more questions. I'll come back to them in a minute. Airway. So any patient with a GCS of lower than 8 is unable, you need to just assume that they are unable to maintain their own airway. Do you guys know what different ways we can help the patient maintain an airway? Do you want to pop that in the chat? Okay, good. Maneuvers and adjuncts. Head, chin lift. Okay, good. So yes, so you can do head tilt, chin lift, jaw thrust. Perfect. You can also use adjuncts, a Goodell, NPA. Good. Yes. So you can definitely use head tilt, chin lift in most cases. If you are worried about a C-spine injury, then you should go for a jaw thrust, as I've mentioned here. When you're thinking about putting any adjuncts or putting in any kind of support, airway support, then you need to call your on-call anaesthetist. You can put in a Goodell or whatever if you have access to it and if you feel that it is safe. But a definitive airway for sure is done by the anaesthetist, which is an endotracheal tube. And someone's written there, basal skull fractures, avoid the NPA. Yeah, that's what my last bullet point was about. Brilliant. Good job. Next, on to breathing. So we're worried about breathing in head injury because we want to prevent any secondary insult to the brain tissue. We want to avoid any hypoxia, which obviously will kill any brain tissue. So we need to ensure that there's adequate ventilation and oxygenation following head injury. Okay, and then onto circulation again. We want adequate tissue perfusion. The blood takes the oxygen to the cells, so we want to make sure that there's a good circulating volume, and we need to use appropriate fluids. The guidelines for this changes, and the guidelines for this also change depending on what age group you're treating. So I would go with whatever the latest NICE guidelines or the latest local guidelines are for your trust in terms of choosing the appropriate fluids. There has been recent debate about mannitol versus saline and so on. So make sure you look at what the latest guidelines are. And then finally, disability. Disability is the point at which you start doing the GCS scoring. This is very important. Ideally, you should do it immediately after a patient has presented so that you can compare any future GCS scores. The GCS score is only as good as if you have multiple, it makes having a trend much easier. So the trend is very important for the GCS. You want to make sure that the patient is getting better or worse. You need to understand what's happening. All right, so we'll go through that in a second. Okay, so here we're going through the GCS. I hope you all can see that. Does everyone know how to score the GCS, what the one or two kind of rules are? Do we take the worst possible score or the best possible response? Best possible, yes. Good. So, yeah, brilliant. So we're going to try, and I hope you can all see this. We're going to try and score these cases with using this for help, all right? So if people can start. So someone's asked, what was the best score? So if you have a patient and, for example, for the motor response, they can have abnormal flexion on one side, but flexion withdrawal from pain on the other side, then you still give them a 4. You try and give them the best possible, best score out of what they can do. All right, so we've got a score here, 7. Okay, so I want to know, yes, perfect. So whoever full stop is, again, as they've done, I want a breakdown of everything that you've written so that I can tell what each point corresponds for, okay? So when you're doing this in the ED or in neuro, wherever you're placed, the doctors will want to know what the eye movement response is, what the verbal response is. So E something, V something, M something should be your answer. Brilliant. Great. So no eye opening means a score of 1. No verbal response, again, means the score of 1. And abnormal flexion on the right means a score of 3, but they are localizing to pain on the left. So brilliant. On to the next one. Any guesses or any M3? Okay, what about E and V? Okay, good. Great. So this patient has, he bends both his arms towards his chest on deep central pain stimulus. So if a person isn't responding to voice, then as you know your AVPU scale, if someone isn't alert, then you ask them to respond to your voice. If they haven't responded to your voice, then you get them to respond to your pain stimulus. And pain can be delivered by a trapezius squeeze. That is probably one of more of the least painful of the different options that we have to give pain. The other one is a stimulus on the orbital bone. You can also press on their nail bed. That's a bit horrible. The last one is a sternal rub. So that's the central pain stimulus. So rubbing on someone's sternum, even if you do it gently on yourself, it really hurts. So doing a sternal rub is quite uncomfortable. So if they are bending both their arms towards their chest, so that means they're localizing to pain. So good working out. It could be abnormal flexion, but at this point, they're localizing to the deep central pain stimulus of the sternal rub to their chest. Okay? Is everyone happy with that? AM, are you happy with that explanation? How would the patient present if they were abnormally flexing? So in this particular example, it might be difficult to tell if they're abnormally flexing. But in this particular example, again, it seems like they are pulling both their arms towards their chest. For example, if I was giving them the pain stimulus on their finger and they were flexing, that would be abnormal flexion, I would say. Or if you were calling out their name and they were just flexing all the muscles in their body, that would be abnormal flexing. Okay, so it depends on what you've done to elicit the response as well. Cool, and last one. Any takers? I've got a couple. Okay, cool. So this person squeezes your hand when you ask them to. So their motor response, they're obeying commands. Okay. They only open their eyes on sternal rub, so they're only responding to pain. So that's E2. And only says the word exams when you ask questions or give a pain stimulus. So I would say that is inappropriate words. So that would be a score of 3. So you're all correct. I think everyone who's said it so far has got it right. Any questions on GCS scoring at this point? No. Okay. If you have any more, then just let me know and we'll try and answer them as we go along. And finally, in the A2E assessment is exposure. So you examine top to toe. So someone who's come in with head trauma might have come in with other trauma as well. So make sure that you can see if there's any other fractures anywhere. For example, if they have a chest injury, a rib fracture, for example, your B might be very difficult and that would have repercussions on the brain as well. So make sure once you've done the initial A to D, you go on to examine top to toe, take off any clothes, etc., and do a full exam. And look for any signs of basal skull fracture. So I've listed here the different signs of basal skull fracture. So the first one is raccoon eyes, which is bruising behind the eyes. So it will look like someone's punched them on both eyes. Battle sign, so that's kind of behind the ear. CSF rhinorrhea, so dripping of CSF from the nose. CSF otorrhea, which is CSF dripping from the ears. Hemotympanum, which is a bulging tympanic membrane with blood behind it. And any obvious penetrating injury, obviously you'll see that first, but make sure to examine all around the head as well to make sure you haven't missed anything. Okay? So I'm going to go back to a few of the questions that came in at the start. If someone's motor score in GCS is 2 or under, what does this mean pathophysiologically? Okay, so let's go back to our GCS. So abnormal extension, decerebrate, is transverse myelitis. I'm not sure if they were both the same questions. So if someone's motor score is below 2 or under, then you need to think about what the lesion is and where this lesion is. So you need to think a bit anatomically. This is a difficult question. I'll have to come back to it at the end. Is transverse myelitis a traumatic brain injury? Transverse myelitis is a pathological process. It's not a form of traumatic brain injury. It's not trauma. It's to do with the myelin sheath, and it's a disease process of that. So it's not traumatic brain injury. Are there more questions? Should we always consider permissive hypotension in trauma cases? That is a very high level management issue that you would have to involve like consultants and registrars, neurosurgical, to make that decision. Not something for us to do, and I wouldn't feel comfortable telling you guys to do one or the other without having a particular patient in mind, or kind of any other data at all. When would you use those methods? Blocks, collars, and tape. So most likely when the patient comes in through with the ambulance, they'll have some sort of C-spine immobilization already. Most likely collar and blocks and tape. The more security you have, almost the better. They might already have all of those in place, and they might have them all at the same time. Collars are difficult because you need to have a good fit for the patient, and it takes a lot of measuring. The last time we did ATLS, we tried to do the whole measuring and trying to find out what's the best fit for patients, and it takes experience to get it right. So the ambulance crew will most likely already have these in place. If not, then the A&E consultants or whoever's in the A&E will know. At a medical student level, you don't need to know if you need blocks or collars or tape. Just know that these are various different forms of stabilizing the C-spine. You can also use hard boards, so they're just kind of literal planks of plastic that patients are brought in on, that just keeps everything straight and everything in anatomical position, make sure nothing moves around. So that's another method that the ambulance crew will bring the patient in with. Yeah. Okay, cool. So let's move on to red flag signs. So there are a few signs that you should look out for when a patient comes in with head injury or suspected traumatic brain injury. And I've listed them down here. This can point towards a very serious form of head injury. So make sure you look out for these. And any impaired consciousness, fixed and dilated pupils, signs of basal skull fracture that we went through in exposure, any focal neurological deficit or visual disturbances, seizures or amnesia, so forgetting what happened, and significant headache, nausea, and vomiting. So just remember these, and if you get it in an MCA question or case discussion, you know that these are features of a serious head injury. Okay. Okay, let's move on and onto imaging. So the patients come in so far. You've done a good A to E assessment. You've assessed their GCS. You've made sure there's no signs of serious serious head injury, and you move on now, trying to think about what's going on the inside, what you can't see. So now you want to arrange for a CT scan of the head. This is usually the primary imaging modality that doctors will go for. It will quickly identify any critical pathology like a skull fracture or traumatic intracranial bleeding. So I'm sure some of you would have seen images of CT heads with extradural hemorrhages and subdural hemorrhages and so on. So you can see all of those on a CT scan, and it's really quick. MRIs take a long time, but CT is really quick. You can see the bone, you can see any bleeds. So it's very good for this kind of scenario. Okay. Not all head injuries will need an immediate CT head. There are certain indications for getting a CT head within an hour versus within 8 hours or longer, and so on. So make sure that you've done a thorough ABCDE and that you've looked for any features of serious head injury. Okay, so the indications for CT within 1 hour: GCS below 13 on the first assessment or below 15 at 2 hours after the injury. Any signs of basal skull fracture, again, so that part in E comes in handy. Any open or depressed skull fracture, post-traumatic seizure, more than one episode of vomiting, it's so important that I've doubled it, signs of basal skull fracture, and any focal neurological deficit, so any focal weakness or paresthesia. So this all comes in when you're examining the patient. Okay. Any questions so far? No. Okay, cool. Let's move on to indications for CT within 8 hours. So just to reiterate, this is for adults. This is not for peds. So peds have a separate set of guidelines. I've linked the NICE guidelines website 2 slides away. So you can, when you get these slides, or you can have a look at the videos again, and you can, or you can type into Google NICE guidelines for CT head after head trauma, and it will come up. So these are for adults. There is a separate set of guidelines for pediatric patients. And indication for CT within 8 hours. So this is a bit more complicated. You have to remember a few more things here. So if the patient is on an anticoagulant, or if they've suffered a loss of consciousness or memory loss, and any of the following signs. So if they're aged over 65, if they've had a history of bleeding or clotting disorders, a dangerous mechanism of injury. So this is a fall from a height. This is something like an RTA, not like a head-on collision. That would probably be a 1 hour CT, but a cyclist versus a vehicle, something like that. and more than 30 minutes of retrograde amnesia of events before the head injury. So any of these, you're less worried than the 1 hour indications, but you are still worried and you want to get them in within the 8-hour window. All right. So here I've put down the algorithm that the NICE website puts on their website. The links are here. You can access them and see for yourself. Does that include patients on anticoagulants? Yeah, so that is one of the main criteria for 8 hours. So this and any of the following. Okay. Okay, and finally, a little bit about history taking. So what should you ask a patient or a collateral history? So if the patient is not compromised, then get a first-hand history. And when when I say not compromised, I mean their GCS isn't low and they're not confused and they're alert and talking to you. Then always get first-hand history about what happened. This will also allow you to assess for any amnesia and so on. If they are compromised, then try and get a collateral history. That could be from an observer, that could be from the ambulance crew, or any relative that might have seen what's happened. So you want to know what the nature of the injury is. Was it high or low energy? Did they fall from a height? What the mechanism was? Were they hit, etc.? Was there drugs or alcohol involved? Were there any red flag symptoms? So things we've talked about earlier. Any known bleeding disorders and their use of anticoagulants or any other medication history would be useful actually. Any comorbidities that they might have, and any previous neurosurgery that they've had, that will all be very useful. Okay, so now we're on to some multiple choice questions. So I'll give you some time to read through all of it and then I'll open the poll and we can talk through it afterwards, all right? So have a go. Have a go at reading it and I'll open it in just a minute. Okay. I'm going to launch the poll so I can see who voted. Oh, whoops. Well, I've given the answer away, but we can talk about it. All right. Okay, so I'm going to close it there. If people want to give me a reasoning for why they've chosen particular GCS scores, do you want to give me a breakdown? Someone want to explain why they chose 7, someone 8, 9, and 10, so on? E2, V2, and 4. Okay, anyone else? Okay, so this man is brought into A&E after being knocked off his bicycle by a motor vehicle. He lost his consciousness. So he is responding to pain. So he opens his eyes on pain. So E is 2. Okay, and then withdraws his arms away. So he's taking his arms away from pain. Good. He's also muttering words, so let's take that as inappropriate words. It's not just sounds, it's inappropriate words. So we'll give him a 3 for voice, and we'll give him a 4 for his motor response. So I would say he's E2, V3, M4. Does that all make sense? Muttering words can also be confused. Yes, I agree. I agree. That's true. Oh, we could give him a 4 if we're assuming that in this case, we'll take that as a best response. Yeah, totally valid. So I gave him a GCS of 9, based on this presentation. But you're right, it could be confused, and we could give him an extra. Right. All right, next question. I'm going to give you guys a minute to think about it, and I'm going to open the poll. Okay, I'm going to launch the poll. If you've finished reading it, you can start voting. Great, it's 100%, 100%. Everybody thinks it's a basal skull fracture. Brilliant. I'm going to end it there. It's unanimous. Okay, so this 32-year-old man, he's brought into hospital after being knocked off from his motorcycle by a car. He's lost consciousness, but his GCS has been maintained at 15 throughout. He has had epistaxis, so that's a nosebleed, and this has resolved after a few minutes. He has bruising around his eyes, so that's raccoon eyes, and behind his ear, so that's Battle's sign, okay? And he's hemodynamically stable, his initial bloods, so all of the rest of it is fine. So yes, so those are the signs of basal skull fracture, if you remember from part E that we talked about. Okay, so anyone want to repeat the different signs of basal skull fracture? There are 5 things, 6 things that we look for. Raccoon eyes, hemotympanum, battle sign, good. CSF drip, yeah. Nose or ears, perfect. Brilliant, great. Yeah, so penetrating injury, yeah, sure. Perfect. I think we've got all of that. Good work, team. So there was a question, what is Lefort fracture? So Lefort fracture, there's 2 types. There's 4 types, I think, maybe 5. It's where it's a maxillary fracture, and each different category is for how much the maxilla has fractured. So you can look that up. It's something that falls between neurosurgery, plastics, and ortho. So it's quite interesting. I watched a surgery of this where we were treating an underbite that a patient had, and it's quite interesting. It's quite gory. So you can have a look online what these are. Someone's put down Radiopedia, hopefully, so people can use that to go and check it out. Brilliant, well done. So that was a basal skull fracture. Perfect. Moving on, we've got another question. This is a bit of a longer read, so have a look, and I'll start polling in a minute or so. I'll open the poll for the fast readers. Okay, we've got about 55% who voted. Any more? Okay, so let's stop there. Brilliant. So most people have gone for D. So let's have a look at this patient's case. So he's a 63-year-old male. What was our threshold for the age for CT head? Do you guys remember? Anyone want to pop it down? Yeah, brilliant. So it's over 65. Good. So he doesn't fit into that category. Let's go on with past medical history. He's got atrial fibrillation. So when someone's got atrial fibrillation, you have to think about what kind of medications they might be on. So he's most likely on a blood thinner to stop him from clotting his blood and shooting off an embolus into his brain or somewhere else. He's a type 2 diabetic. Okay. Tripped and fell onto the pavement whilst out shopping. So it's probably not a very high impact trauma that he's sustained. He's not fallen from a height, so we're okay with that. He's sustained a bang to his head, lacerations to the face, and he's vomited once. Okay. So where does the vomiting fit in? Was it 1 hour or 8 hours? Do you remember? Anybody? Yeah, well done, Matt. So any episode of vomiting, more than one episode of vomiting is usually in the 1 hour. Yeah, perfect. So one episode of vomiting, usually people in any sort of pain can vomit. So the threshold is a little bit higher. So more than one episode of vomiting fits into the immediate CT head category. On admission to the ED, he's alert and oriented with no focal neurology, so he's GCS 15, so that's good. So that doesn't fit into the emergency in an hour CT head, so we're still okay, we're still doing good. He's currently taking warfarin, okay, so that's not good. So got he's got an anticoagulant on board, and his latest INR is 2.5. Okay, a CT head is arranged according to NICE guidelines. Which of the following is an indication for CT? So one episode of vomiting is not. Over 60 years old, our threshold is over 65. Dangerous mechanism of injury, a fall at ground level. It's not. A fall from a height is our threshold. So a history of bleeding or clotting disorder is our go-to. So let's see, what did we choose as a group? So yeah, so most of us chose D. So that's very good. Well done. Okay, does that all make sense? So it's really difficult when you have a longer case like this. You have to go through each bit and kind of tease apart what's happening. But you guys did really well. Okay, so now I have a longer case. We can just discuss what happens in this one. So have a read. Okay. Do people want to tell me their thoughts? What in this case is worrying you? Over 65 on anticoagulation. Good, he is. Both of those things. Are you worried about the mechanism of injury at all? Okay, we have someone who's worried about his small contusion about the right ear. So yes, so let's go through it from the start. So he's 71 years old, and as people have pointed out, that is over 65. So we are a little bit worried. He only tripped and fell in his backyard, so we're not too worried about the mechanism of injury. He hit the side of his head against the brick, but he had no loss of consciousness and he was feeling fine prior to tripping. Okay. And he has a mild headache, but no other injuries. Anyone who's hit the head, we're kind of expecting them to have a mild headache. So we're okay with that. The headache is not out of proportion to his injury. He doesn't have any other injuries. That's good. He has a history of hypertension and atrial fibrillation. So whenever someone says atrial fibrillation, you're worried about some blood thinner that the patient is on, and he is on a blood thinner. So you're worried about the anticoagulation. His examination is completely normal, so we're not worried about a focal neurological deficit. He has a small contusion right about above his right ear. So it could be just from falling on the brick wall on the side, but we're not too worried. We're more worried. I'm not sure if you guys can actually see me. So the battle sign is usually over here, and it's just the wording is quite confusing. It says right just above his right ear, so he could have just done that when he fell on the brick. So we're not too worried. His neurological examination, including memory, is normal as well. Okay, brilliant. So we're not too worried. We jumped onto CT, but what's the first thing that we do with this patient? Brilliant. We're missing a letter there, Andy. Yeah, brilliant. Perfect. So we do our head to toe, so we do our CA to E examination, perfect. And we do a head to toe examination. We ask for a good history. We're all about treating the patient holistically. So even though they've come in with a head injury, you want to take history about what's happened before, find out what the cause was. Was it a mechanical fall? Did he trip? Or was it kind of loss of consciousness, syncope? Are his medications causing this or something else? So a bit of geriatrics comes into play as well. So make sure when you have a neuro patient, the patient is just not just a neuro patient, you know, there's a lot else that's going on. So make sure you cover those bases as well. Take a good comprehensive history if you can. He seems to be conscious, so you can take it from the patient himself. You can also take it from an observer if they're present. Okay, so we've done an A to E assessment. You are not too worried, so you order him a CT head, you monitor him, do neuro obs, so you do your GCS and so on. And yeah, you would do your CT head in what time? Immediately, right now? 8 hours, yeah. So we'll try and get it as soon as possible, but we're not so worried that we get it in immediately within an hour. So we can do it within 8 hours. We can put that as our cutoff, but it usually happens before that, so we're not too worried. His GCS is 15, so I can't really test you on his GCS scoring. But yeah, that's about it. Does anyone have any other questions? I'll just put you guys onto the takeaway message slide. So use your ABCDE as a scaffold for assessment and management as well. So treat as you go along. So if you find that someone doesn't have a patent airway, put in put in an adjunct or use your airway maneuvers. For your GCS calculation, always use the best response. Time is brain, so what you want to do is prevent a secondary injury. Look out for any red flag signs of head injury and aim to get some history so that you can treat the patient holistically. So those are the main takeaways. I believe you get these slides at the end, or at least you can rewatch the videos. But do leave me some feedback. If you have any more questions, I'd be happy to answer them. I'm just going to go back to the top, make sure that I haven't missed anything. So that was a very, very quick whiz through head injury. And I don't think as a medical student you need to know any more. So just memorize a few bits of the GCS and a few red flag things and you should be good to go. All right, thank you guys so much. I believe the Facebook Live is recorded. Hinal and the Becoming a Doctor team can help you best with where you can find it. Yeah, so you can find it on the website, I think. Thank you.